Good afternoon, ladies and gentlemen. Welcome to today's webinar. I would like to remind you that this conference is being recorded. At this time, all participants are in a listen-only mode. For those connected by telephone requiring operator assistance during the call, please press *0. Web participants requiring support should use the chat feature on your screen. I would now like to turn the meeting over to your moderator, Maria Judd, Senior Director at CFHI. Please go ahead.
Hello, I'm Maria Judd, Senior Director with the Canadian Foundation for Healthcare Improvement, CFHI, and I'm your host for today's webinar. Welcome and thank you so much for joining us today. We are pleased to have more than 140 registrants from across the country for this session. As I introduce our webinar and our speakers, I'd ask that you please take a moment to introduce yourself in the chat box, and I see people have started that. It's on the right side of your screen. As well, if you can, let us know how many people are attending from your location using the poll on your screen. On February 8th, CFHI launched a pan-Canadian open call for innovations in palliative and end-of-life care to identify palliative care models and/or practices ready for spread and scale up across Canada. This open call is an invitation and opportunity for innovators and interdisciplinary teams in different parts of the country that are providing excellent palliative care for patients and families to tell us about what they're doing, what is working, so CFHI can help spread and support their uptake across the country. We've launched this call because we know right now palliative care innovations are happening across Canada. And although these innovations exist in Canada and elsewhere, they have not been widely implemented across our country. There is a need to identify and spread integrated approaches to palliative care and to better understand their impact on the experiences, quality of life, and costs for patients, caregivers, providers, and systems. During today's webinar, we'll introduce and explain a little bit more about the open call. We'll explore some of the benefits to you for applying. We'd like to help you assess your readiness to apply. We'd like to share more about how this call is part of CFHI's larger work in palliative care. And we want to answer your questions. Please go ahead and start typing your questions in as you think of them in the chat box on the bottom right-hand side of your screen. We've also reserved time at the end of the webinar and after our speakers for a question and answer period. It may be helpful to have two documents in front of you during this webinar. The first is the call or the prospectus, and secondly, the application form. They are available for download at the link in the chat box on the right-hand side of your screen. I'm very pleased to welcome and introduce our two guest speakers today, Anya Humphrey and Dr. Jose Pereira. As a caregiver to both her husband and son through their deaths with cancer, Anya Humphrey witnessed a medical system populated by wonderful people whose good intentions weren't enough. So she became a member of the first Patient and Family Advisory Council to Cancer Care Ontario. And that has led to participation on many committees at the local, provincial, and national levels with the goal of providing a patient and family perspective on what matters, how to provide that, and how to determine if it's happening. Dr. Jose Pereira is a professor at the Universities of Ottawa and McMaster, a palliative care physician at the William Osler Hospital in Brampton, Director of Research at the College of Family Physicians of Canada, CFHI faculty, Scientific Director and co-founder of Pallium, a not-for-profit organization dedicated to developing palliative care capacity and access by providing palliative care education opportunities for healthcare professionals. And I'm Maria Judd, Senior Director with CFHI, and I'm responsible for developing and implementing strategies, programs, and activities in support of CFHI's mission. And my passion for healthcare improvement has evolved from diverse roles within the health system, including as a community health center board member, a clinician, program manager, researcher, and a daughter. This call is an opportunity to identify and support the spread of better ways of providing palliative and end-of-life care for patients and families. We're going to start our call today by hearing from someone with this lived experience. Over to you, Anya.
Thank you, Maria, and hello, everybody. As I think is true for most people who become patient and family advisors to the healthcare world, I got involved because of a bad experience. I'm going to share parts of that experience with you to explain what motivates me and to highlight why we need to improve palliative care in Canada. When my husband was diagnosed with cancer, at his first appointment with the oncologist, the doctor made it clear that there would be no cure for him and that he should get his affairs in order. He said that the oncologist said that they'd try to give him more time with chemotherapy and he provided a 5-year survival rate. But that was the one and only conversation with anybody at the cancer center in 2 years of weekly and even sometimes daily visits when anyone ever referred to the fact that he was dying. The constant and cheerful refrain was, "There's always something in the cupboard." But of course, eventually all the mainstream treatment options failed, as we knew they would, and eventually Fred was referred for a drug trial. The day we came in for him to sign the papers, a person we had never met before told him that it was a nasty drug, he wouldn't like it, and that he should just forget about it and go home. So Fred went for a 5-minute walk by himself, and then that was it. We left that building with no goodbyes, no contact with anybody that we knew, no discharge plan, and no sense of what would come next. After 2 years of contact with these wonderful people who had literally been our lifeline, the sense of cutoff was just extreme and entirely out of keeping with the rest of our experience there. At the time when we needed them the most, the whole medical team abandoned us. They were very good at helping people live, but they just didn't see it as their responsibility to help anyone die. 3 weeks before Fred did die, our local palliative care team was finally called in, but that was just too late. We didn't know them and they didn't know us. And there were endless details to attend to since Fred chose to die at home. So I spent the last days of my husband's life being interviewed by strangers instead of being able to spend time with him. We were told that the vast majority of deaths are peaceful and that we now had a primary contact person. Whenever we needed anything, we were supposed to call her. So when Fred had a pain crisis the next day, which was a Saturday, and the doctor's office, of course, was closed, I called her. Her response was to set up a conference call with a telehealth number. After 45 minutes of providing medical history, I felt that that was entirely useless, and I said I would figure out something else. So I called the local hospital where I had been told I might be able to reach the family doctor, but their phone system was broken, so I could only reach a fax number. That's the only number there is for our local hospital. So after a few hours, repairs were finally made, and I was eventually able to call in, but the family doctor had forgotten to put Fred's name on the list of people that the emergency room staff were allowed to call him about. But they took pity on me, and they did finally call the doctor, but the doctor's wife forgot to give him the message. And the palliative care specialist, who had given me a contact number to call in an emergency, wrote down the wrong number on her business card. It took 36 hours for us to get any help. Our confidence in the system fell dramatically. We were told that we were entitled to a grand total of 5 nights of nursing care. In the middle of the 5th night, the nurse came to get my daughter and my sister-in-law and me, and she told us that the end was near. And she said she'd had a lot of experience of death, but she had never seen anyone go through what was happening to Fred, and she had no idea what it was or what to do about it. When her shift was over, she went home, leaving us alone for several agonizing hours to deal with circumstances that haunt me to this day. We not only weren't prepared for what we were witnessing, we had no idea that any of that was really even possible. At about the time that we were each privately deciding to give Fred an overdose, another nurse arrived, yet again a person that we'd never met before, and Fred died shortly after that. It is possible that Fred didn't consciously suffer during those hours, but we did. And frankly, it's hard to live with feeling like you've failed your beloved in the last opportunity you have to look after him. that's a brief version of what is for me a very painful and traumatic story. But I'm sure that you're all already aware of many moments when things could have gone much differently. Perhaps most of the time they do go differently, but a system where things can go so badly has certainly not been designed by or for the people it is meant to serve. It's not good enough, especially when the people involved are pretty much universally kind, hardworking, and competent, and their goal is to ease suffering, not cause it. In my opinion, the only way to repair these kinds of failures is to involve patients and families both to provide feedback about how things are actually going and also to work as equal members of teams who oversee the design and delivery of care. So let me talk to you for a minute about patient and family engagement. I've had the great good fortune to be able to serve on many committees and projects at the local, provincial, and national levels. Excuse me, just a sec. And at the beginning, as a traumatized and grief-stricken person, really the only thing I felt capable of doing was to tell my story. And I've been told that that did have an impact. For some people, that might be the extent of their contribution. But as I grew stronger and as the engagement landscape evolved, I've been able to participate in many different ways, sometimes as a committee member whose opinions are taken into consideration, and increasingly as an equal member of teams who have jobs to do, projects to design and implement, reports to write, presentations to give. There have been some difficult moments along the way as we all learn what it can mean to work together and figure out how to do that. But overall, it's extremely gratifying and sometimes even thrilling to be able to work with wonderful people who share the goal of wanting us all to have a kind and a gentle death. The fact that I'm participating in this webinar and that I'm part of the team that's supervising this initiative is an example of how CFHI is really leading the way in patient and family engagement. They aren't just asking you to embed this approach in your work. They've been doing it themselves for many years with great success. So as a person with a big personal stake in improving palliative care, I'd like to invite each one of you who are listening to take seriously this invitation to share your ideas. You clearly have an investment in this area as well, or you wouldn't be hearing me right now. We need a system that is built around the patient and family experience, and we have to work together to make that happen. So just for the last few minutes, I'm just going to go back to my own story and share my personal wish list with you. I need to make clear that these are my ideas and they're not meant to be guidelines or any kind of an official request from CFHI, but I've done a lot of thinking about what would have made things better for my family, and here are some things that I would really like. I would love to see projects that increase the sense of connection between users and providers of healthcare. I'd like healthcare providers to grasp that people need help facing the inevitability of death. I'd like somebody on a person's healthcare team to stay with them for the whole journey. I'd like people to have more information about what a specific death might look like so that they can make better choices about where to be. I'd like every caregiver to have a fridge magnet with a reliable phone number on it to call when they need help. I'd like families of people who died to be interviewed about how it went. I'd like the medical world to send an acknowledgement to the family when their loved one has died. And I would like patients and families to be full partners in making these things happen. They are not happening where I live, but maybe they are in your area. Maybe you're doing something far better than I can even imagine. Whatever you have to offer, please let us know so that others might benefit. We have a lot of work to do, and CFHI is providing this wonderful opportunity for all of us to pool our resources. So, Maria, I'm not sure if I'm to turn it back to you or to switch it over to Jose.
Thanks so much, Anya, and thank you. And thank you for being a partner with us in this. I'm now going to turn it over to Jose to share a clinician and educator perspective on this call.
Excellent. Thank you, Anya. Hi, folks. I thought that today what I would do is to share with you, as someone who has had fairly recent experiences with the Canadian Foundation for Healthcare Improvement, why I think this whole initiative has so much merit and is so exciting, and why I think it's different from a clinician perspective who's been at the forefront of trying to effect change and trying to build programs, both health service programs and also education programs. So I first heard about the CFHI a few years ago, but I must admit I did not pay much attention at the time. But then about 2.5 years ago, I was given quite an amazing opportunity to become a fellow in the Foundation's extra program. I became part of a 4-person team at the organization I was previously working at, Pereira, to join the extra program. So the program, which is a fairly intensive, but I must add manageable, 1-year program, trains healthcare professionals and leaders in effecting change in the healthcare system, and importantly, part of that is quality improvement. The extra program, which I believe has been offered for about 11 or 12 years, involves interprofessional teams from across the country, and most of the years there have been about 10, 11 or 12 teams from across the country, with each team having about 3 to 4 persons. And throughout that 1-year program, we are involved in a number of activities. One of them is online learning with some fantastic modules that we do throughout the year. Then there are also 3 to 4 in-person residential sessions, each of them for about 4 to 5 days, where we come together from across the country, and wonderfully we get to meet face-to-face with lots of the faculty. And that's where I've really seen the potential impact and the real impact that the Foundation has. The faculty that we have access to are people who have been at the front line of health system, working in the front lines and at the forefront of effecting change and innovation across the country. They range from individuals who have been ministers of health, deputy ministers of health, key people in ministries provincially and federally, policymakers, administrators, clinicians, who really understand the complexity of the healthcare system or systems that we live and work in. Now, since then, I've worked with the Foundation in different capacities, and more recently in my role as Research Director at the College of Family Physicians of Canada, where as a college we're rolling out a whole quality improvement program. And again, the Foundation has been so absolutely helpful to us, particularly around understanding change, understanding what it takes to scale up, and understanding what it takes to spread innovation. I've come to know the Foundation and its staff as a team and faculty of world-class quality, who have implemented changes not just in regions but also in provinces and even nationally and internationally. So why do I think that this call is unique and perhaps different? I think many of you, like myself, have over the years attended many different summits and conferences, initiatives, programs. Some of them have been fantastic and have gone somewhere. Others we've worked at for a long time and seem to have hit barriers and have not moved forward. So the question is then, what's so different about this one? I think what's different about this one is, in essence, the CFHI, with its staff and its faculty and its network, has the knowledge, the know-how, how to identify what's innovation, how to spread it, how to scale it up. It has the ear, and I think this is extremely important, it has the ear of federal and provincial policy makers and decision makers. And within the faculty and within its network has very influential policy makers. I've come to know the Foundation as an organization that does make change. It's not just talking, it actually walks the talk and it makes change happen. So I think this is very exciting, because I believe that through that mechanism of knowing the levers for effecting change, the network that they have, that we will see outcomes coming from this fantastic initiative. Thanks very much.
Thank you, Jose and Anya. So this open call is an invitation to let us know how CFHI can work with you in making change happen for patients and families after a diagnosis with a life-limiting condition. We want to identify and support the spread of approaches to palliative care that provide the right care in the right place at the right time. And innovations selected through this process will have an opportunity to be spread through future CFHI programming. Today in Canada, improving access to palliative and end-of-life care and integrating a palliative approach across the continuum of care for people with life-limiting conditions is a priority. CFHI has consulted with, listened to, and learned from many leaders, including clinicians, health system leaders, and families in Canada and internationally to better understand how we can work shoulder to shoulder with health system leaders to improve the experience of health care, the quality of life for patients and families, and the most appropriate use of healthcare resources. For those of you who may be less familiar with our organization, the Canadian Foundation for Healthcare Improvement is a not-for-profit organization funded primarily by the federal government. We were created to help move Canada beyond being a country of perpetual pilot projects. We identify and validate health system innovations and accelerate their spread across the country. We do this by working shoulder to shoulder with you, health system leaders and innovators, to improve health and care for Canadians. And identifying and supporting the spread of best practices in palliative care across jurisdictions is a priority for CFHI in 2017 and 18. We have developed an evidence-based approach to support the spread of innovation and improvement, focusing on building improvement and skill capacity, enabling the engagement of patients and families, applying improvement methodology, and creating collaborative teams from across the country working on adapting and implementing a similar change to spread evidence-informed improvement. Our methodology includes fostering collaborative leadership among managers and providers, setting clear aims within a well-assessed population, developing supportive curriculum in change management, implementation, and performance measurement, and providing peer-to-peer learning and coaching. CFHI knows from evidence and experience, improvement requires engaging stakeholders in a process of change based on our 6 improvement principles, which can be found at the bottom left of this slide and also in the call or prospectus for innovations in palliative care on page 5. So CFHI in this call is seeking palliative care innovations. These include models, programs, approaches, and/or tools that are improving or have the potential to improve the experience, quality of life, and value for money provided by palliative care for people with life-limiting conditions and their families. An innovation can be a new way of delivering care that shows promising results for patients and families, or one that outperforms current practice. This is Appendix A in the call on page 9. This table illustrates types of innovations that are eligible for the call. Now, several of you have asked for more information on these, so we'll take a few minutes to walk through a few examples of innovations that CFHI is already helping to spread. Preview ED is an example of an innovative screening tool developed by Marilyn Obastawi with support from CFHI. It's a tool that helps staff in long-term care detect early health decline among residents related to 4 conditions: pneumonia, urinary tract infections, dehydration, and congestive heart failure. The problem, or the challenge this innovative tool addresses, was that 25% of long-term care residents were visiting emergency rooms, and of these, 25% of the visits were identified as preventable. The innovation was the creation of a tool that takes personal support workers 8 to 15 seconds to complete and identifies early deterioration in residents and their need for care. The results have been a 50 to 70% reduction in transfers to the emergency department across sites where the tool is being used. Personal support workers share that they feel more engaged and better equipped in their roles, and millions of health system dollars have been saved. Another example is the INSPIRED program, a proven or demonstrated innovative model of care that stands for implementing a novel and supportive program of individualized care for patients and families living with respiratory disease. The model is illustrated on this slide. INSPIRED is a holistic, proactive, hospital-to-home form of care, providing specialized support to patients and families living with late-stage COPD. Services include self-management, education, action plans, psychosocial and spiritual care support, and advanced care planning. And the model really links services and support between the hospital, home, and community. The INSPIRED Outreach Program was developed by Dr. Graham Rocker and team in Nova Scotia. CFHI identified the opportunity to help spread this demonstrated innovation. In 2014-15, CFHI worked with 19 teams from healthcare organizations in all 10 provinces in an improvement collaborative to transform care for people living with COPD and support their caregivers. CFHI supported teams to adapt and implement this inspired approach to COPD care that reduced by 60% emergency room visits, hospital admissions, and days in hospital among patients participating in the program. Patients and families experienced improvements in care and quality of life. And several provinces are now considered scaling up this inspired program. So are you an individual or part of a team with an emerging or demonstrated innovation in palliative care? We really want to hear from you. Eligible innovations can be emerging or demonstrated. So emerging innovations are promising practices or emerging ways of improving palliative care that may be too new to have results. This category includes innovations that have been implemented and also evidence-based ideas or conceptual designs for improving palliative care that may not have been fully implemented yet. Demonstrated innovations are ones that have been implemented and are showing evaluation results. The innovation may have spread or been scaled up to one or more sites beyond the original pilot site. And over the next 6 to 9 months, CFHI will invest up to $250,000 in up to 10 teams from both of these categories. Over the next 5 minutes, we'd like to respond to common questions that we've had since the launch of our call. Who should apply? Why apply? How will the innovations be selected? How is this call part of CFHI's programming? What are the timelines, and who do I contact to learn more or to have a conversation? If you have questions, please start typing them now into the chat box on the right-hand side of your screen, and we'll respond to many of them as we go along, and also we have time reserved for some question and answer and discussion at the end of the webinar. In our experience, there are a wide range of roles that individuals who are innovators may play. And most successful innovations are created and implemented by teams, often with diverse roles and perspectives. Teams and individuals from healthcare organizations, both public and private, community, government, and social service sectors in Canada are welcome to apply. Please see page 4 in the call or the prospectus for more information. So why apply? And the question already came in through our chat box in terms of will there be funding available for this call. So for innovators that are selected through the merit review process, which I'll talk about more in a few minutes, selected innovators will have an opportunity to receive a 2017 CFHI Innovation Award. And this is really an opportunity for recognition and visibility both by peers and health system leaders. And those will be presented in June at our CEO Forum. Secondly, the costs will be covered for travel and accommodation for selected innovators to come and present their innovation, either as part of a panel session or a storyboard poster to health system leaders from across the country at the CEO Forum we'll be hosting in June in Toronto. And thirdly, they will have an opportunity to benefit from CFHI support, to identify opportunities to spread your innovation. There are more details about what that support will look like because we have received some questions coming up in the chat box in a moment. As I said, CFHI will invest up to $250,000 over the next 6 months with up to 10 teams to work with them to prepare, assess, and support their readiness for spread of their innovation. So this support includes networking opportunities with health system leaders and other innovators, potentially, if needed, support for enhanced evaluation, expanding data collection, or adding a return on investment analysis to an evaluation underway or completed, support for assessment to support to assess readiness for spread. We can also provide release time to work as part of the design team to help CFHI develop a new spread collaborative on palliative care. And we will offer prominent profile on our website and supported by an integrated marketing campaign. So for those selected through this process, we want people to know about what's happening and the impact that that's happening across the country. So how will the innovations be selected? We are assembling a merit review panel, and each application will be reviewed for eligibility by CFHI staff and validated by the chair of the merit review panel, Terry Sullivan. Each application will be reviewed independently by at least 2 external peer reviewers, and we will ask peer reviewers to declare any conflicts of interest when participating in the merit review process, and certainly to be excluded from the review of any applications they may be associated with. Each application will be discussed and review a final review and rating during a meeting of the merit review panel members and CFHI staff in early May. Merit review panel members will be identified by peers as leaders in palliative care and will arrive at a consensus rating for each application. In identifying merit review members, they are peer-nominated, professionals in the field. They will include patient and family members and experts in health services change from across the country and from different care settings. The merit review panel will consider 2 really core questions in their review. And the first is, to what extent is the innovation relevant to an integrated palliative care approach to care? So themes or elements of an integrated palliative approach that the merit review panel will look at may include, but are not limited to, team-based palliative care education, policies or models that improve access to palliative care, approaches to identify palliative care needs and support for palliative care planning, the engagement of and support for patients' families, coordination of care by teams across settings, and the use of technology to enhance care. The second core question the merit review panel members will ask and the criteria that they will rank and assess innovations against goes to the heart of, is the innovation ready for spread? So guided by criteria outlined in CFHI's Readiness to Spread assessment, which we co-developed with leaders at Kaiser Permanente in the U.S., merit review panel members will assess, based on information provided in the application, the extent to which an innovation is ripe for successful spread. So this includes looking at how clear and well-defined the innovation is, the extent to which the innovation accomplishes performance objectives, does it accomplish what it's intended to, the extent to which the innovation can be applied to other settings, is it going to be generalizable, the likelihood of successful spread, and additionally, consideration will be given to ensuring that selected innovations collectively include multiple organizations and diverse perspectives and represent different contexts for palliative care delivery across the country. More information on this is on page 6 on the prospectus or call for innovation. So here's a recap or an overview of where we're going over the next 12 months and how CFHI will be supporting the identification and spread of best practices or innovations in palliative care. So for the past several months, and will be ongoing, we have really benefited from the input from organizations and leaders already playing a key role in palliative end-of-life care. We've launched our call for innovations, and that will be open until April 5th. We are assembling our merit review panel, and they will meet in mid-April to review all of the applications. and make selections and recommendations for CFHI both in the emerging and demonstrated categories. Selected innovators will be notified of their acceptance and invited to come and participate in the CEO Forum by May 10th. The CEO Forum provides an opportunity for health system leaders, palliative care leaders, and innovators to meet together to better understand the innovations and to start to discuss and further unpack what would be the barriers and enablers, both from a policy and practice perspective, in spreading this approach to care. Coming out of that, we'll be moving into designing a spread collaborative in palliative care towards the end of this year with the goal of having 2 streams of palliative care programming in place by early 2018. First, we would like to launch a spread collaborative which will profile 1 or more of the demonstrated innovations identified by merit review panel members through this process. Secondly, we will invest in and help cultivate emerging innovations identified by our panel. A key activity along our programming development timeline is our 8th CEO Forum. This is an invitation-only forum in its 8th year, and it's long been regarded as a venue for senior leaders from healthcare organizations, community, government, and social service sectors to build relationships and expand networks. One of its overarching goals is to speed the spread of health system and care innovations that improve health for Canadians. This year's objectives are very focused on palliative care. First, to discuss identified innovative practices in palliative care that may be ready for future spread and or scaling up to other organizations or jurisdictions. And secondly, to provide a venue for senior leaders to connect and form coalitions of the willing to help accelerate the spread of proven or promising innovations that can transform how we approach and deliver palliative care. So we want to cast the net wide with this open call, and we welcome your questions, your feedback about eligibility, benefits, or anything related to this call and CFHI palliative care programming. We hope you will consider applying and working with us. If you have further questions, please, or you'd like to have a conversation with CFHI staff about this opportunity, please contact Jessie Checkley, and her information is in your packages. Together, let's make change happen. To learn more, please look to our website for additional resources that can be downloaded. At this point in time, I'd like to invite further questions from you that you may have had that have either you had coming into this call today or have come up as the speakers have been sharing during the last few minutes. Please take a moment and type them in the chat box, and we'll do our best to respond to them during this webinar. So the first question I see coming in is looking for some clarity about how the $250,000 will be invested, and that's correct. That's the total amount over the next 6 to 9 months, and it's not per innovation selected. So that's $250,000 for up to 10 innovations, and those innovations could be submitted by 10 individuals or 10 teams or a mix of individuals or teams. And that investment of $250,000 will be across the innovations selected through our merit review process. And we anticipate from experience that the investment between teams may look different depending what the needs are to enhance their evaluation or to support the readiness for spread or to start to spread that innovation. Next question comes from Cancer Care Manitoba. Is the October to December Design Spread Collaborative the end of this program? No, it's actually in some ways the beginning of designing a formal collaborative, which we will launch an open invitation for teams to participate in 2018. So this call is really part of the design of palliative care supportive programming that we will have in the field in 2018. So this call is an opportunity for us to identify innovations or an innovative model that is ready for spread. Then we will design with the innovation and innovators and team a program. So that design period is really new program design timeline between October and December for a program launch in 2018 where teams who want to implement a different approach to palliative care will have an opportunity to be part of probably a 12-month period, a really structured journey of change, as Dr. Pereira referred to. And I sort of described the support as a really structured opportunity with lots of support for making change happen. So it's not something you have to do or off the side of the desk, but it's education, it's peer coaching, networking, measurement support, and so forth. So that would launch in 2018. Next question comes from Barb Andrews. Would a U.S.-based organization with significant activity throughout Canada be eligible? So yes, we would welcome you to apply. This is really aimed at improving palliative care in Canada, and we would put that to the merit review panel for assessment. Next question comes from Cheryl Cameron in Alberta. Is the money and support directly related only to the spread component, or are there money to benefit teams locally to enhance practice? So great question. Thanks, Cheryl. So for this call, the money, the investment will be to support either for emerging innovations, enhancing the evaluation of that innovation, or for demonstrated to assess and to support the spread for the innovations and the teams who have created those innovations in this phase of the work. So that's in 2017. In 2018, when we launch a new program calling for teams to apply to participate in a spread collaborative, will they have an opportunity to adapt and implement a different approach to palliative care in their local context. There will be different investment made, and that will include, but not be limited to, seed funding for teams on implementing innovations selected through this call. Michelle Howard asks a great question. If the innovation was designed by a team, who should be the primary applicant? So really up to the team to determine. We have asked for a primary applicant because we need a primary contact person, but we do recognize that many innovations are created by teams, and so we ask that you do list all of the team members in your application, but decide amongst your team who would be the primary applicant and primary contact for CFHI. So we'll just wait for another moment to see if any other questions come in. We have had a number of calls and emails over the past several weeks from individuals, and I'll take a moment to share those questions and our responses to those questions now while we're waiting for new questions to come through the chat box. Somebody did ask if they had a program or a regional program that had a number of components to the program, would we recommend them submitting the program as an innovation or the components of the program separately?
And it's Jose here. So I think one way to approach that is if that whole program requires, is dependent on its various components to function. In other words, a component does not necessarily function independently, but is dependent on the others, then we would suggest it being submitted as a whole. If the components, if there are innovations of each or one or two of the three components or more components, if there's innovations of that particular component and that can function independently, then submitted as a separate submission. But please do describe how it links up to a larger program.
Great, thanks, Jose. Another question we received via email previous to this webinar today was from someone saying that their program had recently been recognized by Accreditation Canada as a leading practice in palliative care, and would they still be qualified to apply? So yes, absolutely, we would welcome applications highlighting innovations and practices that have already been recognized elsewhere. Absolutely. A third question that came in is, will the call be recognizing bereavement as part of the area of practice? And the answer to that is yes. And actually in the footnote on the call for innovations, or the prospectus, we did define, for the purposes of this call, what we meant by palliative care, including support and care that someone would need from time of diagnosis with a life-limiting condition through to bereavement. So question from Jamie, can the funding be used to purchase technology to support innovative practice change? So if that's something that is needed to help get an innovation ready for spread, that would be something that could be eligible for funding, yes. So if you have any other questions or comments, we invite you to share them through the chat box. We're just checking to make sure that we've hopefully responded to each of the ones that are there. Where is it? So a question about, since 2018-19, will there be continued investment? What is the plan for that? So yes, there will be continued investment in palliative care programming from the foundation. There will unlikely be another call for innovations in palliative care, because the purpose of this call is to help us identify innovations that will be profiled as part of a spread program that will be rolled out in 2018. So teams who will be invited to be part of that spread collaborative, who express an interest and a commitment to introducing and to adapting the innovation or package of innovations to their local context, will be part of CFHI future programming, which will start in 2018 and go through to 2019. And teams who are applied to and are selected to participate in spread collaboratives receive a different kind of support from those who are innovators. And that includes education, coaching, networking, measurement, support, change management, coaching, and seed funding as well. So that will be 2018 through to 19. And because that program is still to be designed, it will very much depend on the innovations we receive and that are selected by the merit review panel for this call. I don't have more specifics on that program at this point in time, but that will certainly be coming. So thank you for those questions, both of folks who emailed in beforehand and who are asking questions on the line. If we didn't get to your question, if we missed it in the chat box, we apologize, and please do email us or contact Jessie Checkley. She'd be happy to correspond with you either by email or to have a conversation to further unpack the opportunity and also have a better sense of the kind of support that you would foresee would be needed and helpful to spreading your innovation. Oh, sorry, there's one more question come through the chat box, I'm told. Great. Question from Cheryl Kim, and seed funding would be for other areas of the country wanting to pick up the innovation. Correct. Not for the team that is spreading the innovation. So thanks for that clarification, Cheryl. So there's two kinds of funding. Seed funding would be for, yes, teams in other parts of the country who may apply to and be selected to participate in our spread collaborative programming, which would launch in 2018. And this investment that we're talking about is support for innovators. So often we provide, release time for innovators so they can be part of designing that collaborative, which will help spread the innovation they've been a part of helping to create and implement across the country. So two different kinds of support, both involving financial investment to innovators and innovative teams to help us further assess and get that innovation ready for spread, and to recognize the time that they will contribute to that. And then secondly, seed funding to teams once that program is designed to implement those innovations. So thank you so much again for your questions, and please don't hesitate to contact us if you think of questions following today's webinar. Please do download the application and let us know how you're approaching providing palliative and end-of-life care for patients and families in your area of the country and in your communities. We'd love to hear from you and explore how we might work together to spread that across the country. We hope that you found this session informative and that you'll join us again in the near future. Your feedback is really valuable to us to inform our future programming and our future webinars. We do ask that you take a few moments to provide us with some feedback on today's session, and a poll should be coming up on your screen. I'd like to thank our speakers. Thank you so much, Anya, for sharing, just for being with us today and for working with us, and Jose for their excellent presentations. And to everyone for taking time out of your busy days to participate on this webinar. We hope we'll hear from you soon. This concludes today's webinar. Have a great day.
Ladies and gentlemen, this does conclude the conference call for today. You may now disconnect your line and have a great day.